Welcome to the prostate cancer part 25, part A, acute spinal cord compression from metastasis. Symptoms from acute spinal cord compression depend on the level and degree of compression. Metastases from prostate cancer often occur in the lumbar spine, which correspond to the sacral spinal cord and cauda equina. Therefore, neurological symptoms tend to involve the lower extremities, bowel, and bladders. Symptoms may include weakness or paresis below the level of injuries, sensation loss below the level of injuries, urinary fecal incontinence or retention, and back pain. This is a symptom. A start intravenous steroid commonly used dose is dexamethasone 100 milligram IV bolus followed by dexamethasone 25 milligram per oral QID per 3 days. Thereafter, the dose is tapered slowly. A start intermediate or immediate androgen deprivation by one of the following methods. We can use bilateral orchidectomy. Testosterone reach the castrate's level in 2 to 12 months. Or we can use ketoconazole 400 milligram per oral cure with 8 hours. Castrate testosterone level are often reached by 8 hours after 400 milligram oral dose. Or gonadotropin releasing hormone antagonist. This agent do not cause flare and do not give luteinizing hormone releasing hormone agonist because the flare can make spinal compression acutely worse. Plain spine X-ray may be obtained. However, it's probably better to obtain an MRI of entire spine. This will identify not only symptomatic lesions, but also lesions that might cause impending problems. Surgical decompression might be indicated in any of the following cases. We can do compression if a failure of androgen deprivation and radiation, or if we have spinal instability from vertebral body collapse, or we have recurrent spine compression in area of previous radiation therapy, or bone protrusions into the spinal cord, neurological compromise from spinal metastasis. External beam radiation therapy to the spinal metastasis should be instituted immediately if surgical therapy is not indicated. Neurosurgery, radiation oncology, and medical oncology consult might be helpful in managing patients with cord compression. Androgen deprivation. Androgen, source of androgen in men testes produce 90 to 95% of circulating androgen in the form of testosterone. Luteinizing hormone stimulates testosterone production in the testicular leading cell. Adrenal gland produce less than or equal 10% of circulating androgen in the form of androstenedione or androstenedione and a dihydroepiandrosterone. So this is the adrenal gland secrete the androgen in form of androstenedione and dihydroepiandrosterone or DHEA. That is less than 10%. Less than 10% or equal 10%, but the testes secrete 90 to 95% from leading cell. In most reproductive tissue, testosterone is converted by 5-alpha reductase to dihydroepiandrosterone or dihydrotestosterone, DHT, which has a higher affinity for the androgen receptor than testosterone. Prolactin decrease testosterone by inhibiting gonadotropin-releasing hormone secretion from the hypothalamus. Even though prolactin reduces testosterone, it might accelerate the growth of prostate cancer by directly stimulating the prostate tissue. Condition that increase prolactinemia, hypothyroidism, stress, chronic renal failure, stress and chronic renal failure, and certain medication like phenothiazines. Definition: androgen deprivation therapy can be defined as any therapy that reduces the ability of androgen to activate the androgen receptor. However, androgen deprivation therapy usually refers specifically to castration with or without concomitant use of a first-generation anti-androgen. Castration defined as treatment with surgical castration, bilateral chilectomy, or medical castration, luteinizing hormone releasing hormone agonist or gonadotropin releasing hormone antagonist. Medical castration is reversible, while orchidectomy is irreversible. Luteinizing hormone releasing hormone agonist, gonadotropin releasing hormone antagonist, and orchidectomy are equally effective in controlling prostate cancer. There is limited evidence that the orchidectomy and gonadotropin releasing hormone antagonists are safer than luteinizing hormone agonists because they are associated with fewer cardiac events, especially in men with non-cardiovascular disease. Combined androgen blockade defined as treatment with castration and first-generation non-steroidal anti-androgen. Combined androgen blockade provide limited benefit over castration alone. Monotherapy defined as use of only one medication for androgen deprivation therapy, neoadjuvant before curative therapy, adjuvant after curative therapy. Castration naive defined as no previous treatment with castration. Castration sensitive prostate cancer defined as prostate cancer that has not been previously treated with castration naive, or that is responding to the castration, I mean the PSA and cancer volume are not increasing. Castrated sensitive prostate cancer is also called hormone sensitive prostate cancer. Castration resistant prostate cancer defined as prostate cancer that is no longer respond to castration. I mean the PSA or cancer volume is increasing even so serum testosterone is less than 50 nanogram per deciliter. Surgical summary of androgen deprivation: we have bilateral orchidectomy, we have hypophysiectomy, and we have also bilateral adrenalectomy. This is surgical. Pharmacological: estrogen, progesterone, prolactin antagonist, luteinizing hormone agonist, gonadotropin releasing hormone antagonist, inhibitor of androgen synthesis, anti-androgen non-steroidal or steroidal 5-alpha reductase inhibitor. All this is considered as pharmacological. Surgical androgen deprivation, bilateral orchidectomy. Surgical castration orchidectomy is the gold standard for androgen deprivation. Castration testosterone level occur 2 to 12 hours post-operatively. Mechanism of action: remove the testis as a source of testosterone. Orchidectomy eliminates more than 90% of circulating androgen. The remaining androgen arises from the adrenal gland. Advantage: low cost, does not require compliance with medication to maintain castration. Orchidectomy does not cause a testosterone flare or microsurgery. Side effect: already discussed side effect. Hypophysiectomy, ablation of the pituitary. Mechanism of action: the source of luteinizing hormone and ACTH is removed. Therefore, testicular and adrenal androgen production is inhibited. Not used anymore. Pharmacological are now used instead of hypophysiology. Bilateral adrenalectomy mechanism of action: remove adrenal as source of androgen. Not use anymore. Pharmaceutical or pharmaceutical are now used instead. Pharmacological androgen deprivation. Estrogen mechanism of action inhibit the hypothalamic pituitary axis, which decrease luteinizing hormone releasing luteinizing hormone secretion, and therefore decrease the testosterone production. Estrogen increase the serum prolactin, but they do not cause testosterone flare. Testosterone reach castrate level in approximately 10 to 14 days, range of 10 to 60 days. Example, we have diethylstilbestrol, DES. This is a good example of estrogen, and we mentioned that the testosterone reached the castrate level in approximately 10 to 14 days. Lead to inhibition of hypothalamic pituitary axis, decreasing luteinizing hormone secretion, and therefore decrease testosterone production. We have diethylstilbestrol, this, or pyramarine, and estridiol or pyramarine, or diethylstilbestrol. This is example of estrogen. Side effect: embolic, pulmonary embolism, DVT, stroke, cardiac myocardial infarction, and to lead to peripheral edema, painful gynecomastia, erectile dysfunction, weight gain, alert fat distribution. So this pyramarine and estridiol and diethylstilbestrol, it will lead to painful gynecomastia, peripheral edema, erectile dysfunction, weight gain, alert fat distribution. Estrogen do not cause hot flushes or osteoporosis. When using estrogen, consider prescribing an anticoagulant such as aspirin or Coumadin to reduce the potential risk of embolic complication. Diethylstilbestrol, or what we call it diethylstilbestrol, 3 to 5 milligram per day, has significant cardiovascular risk. Diethylstilbestrol, 1 milligram per day, delay the progression of advanced prostatic cancer, but have a much lower cardiovascular risk. However, castrate testosterone levels are not reliably reached within 1 milligram per day. DES may also be given IV. Progestin mechanism of action inhibit the hypothalamic pituitary axis, which decrease luteinizing hormone secretion and therefore decrease testosterone production. Progestin do not increase serum prolactin. Progestin causes transient reduction in serum testosterone, but then there is a gradual rise in testosterone. I mean, there is no escape phenomenon. Thus, they are usually not used alone to treat prostate cancer. This agent do not cause hot flush. Example, migestrol acetate, or known as Migas. We have good example, another example, cybrotron acetate. Cybrotron is not available in US, so migestrol acetate and cybrotron acetate, this Progustin, this agent does not cause hot flush. Okay, this is the end of part A out of 25. We'll meet again in another session.